Hello everyone, this is Avijit Barai. In this video, we are going to talk about Takotsubo cardiomyopathy. It is also called stress cardiomyopathy or broken heart syndrome. I'll explain to why this is called in different names. I'll show you some echocardiography and some unique ECG features for this condition as well. Along with me, I have got Rebecca. I will call her Becky. She's fantastic in interpretation of the ECGs, and also she's got some very good understanding about various aspects of medicine. So thank you, Becky, for being with us.
Hello everyone. I am Becky. As always, I am very excited to be here. Over the next few minutes, we are going to show you some awesome ECGs with a lot of animations and up-to-date information.
Okay, so this is what we're going to do. Let's do some signposting at first. So we'll talk about what is Takotsubo cardiomyopathy and how to diagnose it on the basis of the history, the examination, and some relevant investigations. When you talk about investigations in Takotsubo, obviously the most important investigations are ECG, echocardiography. There are some other investigations that are relevant, for example, an angiogram, troponin, but again, some of them may not be relevant in clinical practice, in emergency medicine, or in urgent care settings. As a physician, our job does not end at the diagnosis, so we'll talk about the management of this condition as well. So first of all, let me tell you about a patient that I have seen a couple of months ago. So I was working in a small rural emergency department where not high acuity patients are seen usually. There is some limitation with resources. There is no access to the cardiology straight away. We need to call retrieval services like either a fixed wing retrieval, which takes about half an hour to fly to the nearest cardiology department. Otherwise, we can call a helicopter or rotary retrieval service. That also takes about half an hour to 45 minutes to transfer an emergency patient. So it was the weekend, and I was working there on my own. I saw this 64-year-old female who presented with some dull pain in the chest, and that was constant in nature. It was moderate to severe in intensity, radiating to the left arm, and it is constant. It is going on for the last 24 hours since day before. But she was not very keen to see a doctor. She had a friend who was a nurse, and she got very concerned. So the nurse friend brought this 64-year-old patient to us. On further inquiry, we found that she was fit and well. The only issue she had was she has got chronic smoking history. On further questioning, we found that there was some interesting stuff on her social background. Her husband died recently, 3 weeks ago, from a heart attack. So obviously, it was a very stressful condition. And then her cat was killed by the dog. And a few days later, her chicken was killed as well by the same dog. So she watched this unpleasant and very difficult situation in front of her eyes. Um, and then the family and the friends, they decided to kill that dog as well. So this is a very important piece of information from this particular patient. So her husband died 3 weeks ago, and her cat was killed, her chicken was killed, and the dog was killed. On the basis of this relevant investigation with a patient who comes with chest pain, our differential diagnosis will always be, could it be an MI? Could it be an anstomy? Could it be an aortic dissection or a pulmonary embolism? So these are the life-threatening conditions which we think about as an emergency physician. But also, when the patient gives this information about the social stress, then we also think about something else. We'll talk about it in a minute. So on examination, I found that she was apyrexial. She was comfortable. Initially, she had some pain. We have given some painkillers, but otherwise, the vital observations, they were fine. The pain score was 4 out of 10 on arrival. We have given her some intravenous fentanyl, and that controlled her pain very well. She looked well as well. So we did a 12 lead ECG, and this is the ECG. Now, if you carefully look at it, I would suggest press the pause button of the video and spend about 30 seconds to interpret the ECG in a very systematic way. You will see that there are some obvious abnormalities in the ECG, but also there are some very interesting findings, which we will explain in a few slides later, which can help us in the diagnosis of this very unusual condition. As you can realize from the very first slide, we are talking about Takotsubo. So this particular ECG is actually representing Takotsubo. So let's talk about Takotsubo a little bit, and then we'll come back to that ECG and explain the various aspects of the ECG and show you some echocardiogram as well. So what is Takotsubo? The Takotsubo is basically, it's not a permanent condition. It's a transient condition, and it does not affect the whole of the heart. It usually affects a little part of the heart. Most common in 80% of the cases, the apex of the heart that is affected. This is not an MI, but it can mimic an MI. Most of the time, the patient's left ventricle is affected, but there are some conditions in about 1/3 of the cases where both ventricles can be affected. But this is the left ventricle that causes all the problems like pulmonary edema, cardiogenic shock. So we need to think about that at first. Um, One of the feature which is helpful in the diagnosis of Takotsubo is that if the patient is taken to the cath lab and angiogram is done, it does not show any features of acute coronary syndrome in terms of a blockage or narrowing of the coronary arteries. So essentially, the angiogram is negative. If we do that echocardiogram, that also shows as a unique feature in Takotsubo, that is wall motion abnormality. This wall motion abnormality can be complete standstill of the wall of the ventricle, that is called akinesia, or reduced movement of the wall of the ventricle, that is called bradykinesia or hypokinesia. Um, and this particular abnormality can be found in different parts of the heart, most commonly found in the apex, but also it can be found globally in rare occasions. There are some eponyms that many authors, many clinicians use. We will use the term Takotsubo because that is the original term, but some of the authors call it stress cardiomyopathy, as this particular condition is associated with various types of stress. For example, it can be a physical stress from exertion, it can be an emotional stress like a death of some near or dear one, breakup with the partner, some work-related problem, financial stress like losing the job, um, uh, defaulting the mortgage, any type of stress. Now, most of the time we talk about negative stress, so something negative, something bad. But interestingly, there is a Takotsubo worldwide database, and that shows that there is 5% of the cases where it can be positive stress that is associated with Takotsubo. So if somebody is too happy, somebody won a lottery or went to honeymoon, they can develop Takotsubo as well. On the basis of the echocardiographic finding, which is found in about 80% of the cases, this condition is also known as apical ballooning syndrome. I have some personal reservation in calling it as apical ballooning syndrome because there are 20% of the cases where the apical ballooning is not found. There may be global or basal or mid-ventricular dilatation or akinesia or hypokinesia. Um, Coming back to the stress cardiomyopathy, some call it a broken heart syndrome because of the obvious fact that some negative stress like death of the cat, dog, or chicken can cause it, like in my patient. So it's called broken heart syndrome. But as I've just explained, that there is the worldwide Takotsubo database, which shows that about 5% of the patients can have happy heart syndrome. And there is some medical literature. I'll refer that to you in a few minutes' time, where this condition is also called happy heart syndrome. So if you do the literature search, don't just look for Takotsubo, look for also stress cardiomyopathy, apical ballooning syndrome, broken heart syndrome, and please also look for happy heart syndrome. Now, this first term, Takotsubo, is a Japanese word. It was first talked about in some Japanese literature in the 1980s. The reason it is called Takotsubo is because in Japan they use a special pot which looks like this for catching octopus. this particular pot is called Takotsubo. And as you can see from the morphological appearance of this, the bottom of the pot is a bit dilated, but the base, which is on the left-hand side, that is a bit narrow. As you can realize that the heart is other way around. So the apex is narrow and the base is dilated. But in Takotsubo, the apex gets dilated. That looks like that pot which is used to catch octopus in Japan. That's why it's called Takotsubo. So this is from a Nature article. And as you can see on the left-hand side, this is the normal heart. So this is the right ventricle, this is the left ventricle, this is the right atrium, this is the left atrium, this is the ascending aorta, and this is the aortic valve. As you can see on the left ventricular apex, it's quite narrow. And what happens in Takotsubo is, we don't know exactly what happens, but this is a hypothesis that there is some increased amount of catecholamines like adrenaline, noradrenaline, dopamine, and that get concentrated in certain parts of the heart. In 80% of the cases, that happens in the apex of the heart, that is here. And what it does, it causes some microvascular vasoconstriction that decreases the blood supply to the apex, and that causes hypokinesia, and that causes the dilatation of the heart. So with a few days or few weeks, the apex of the heart gets dilated. And again, I am re-emphasizing the fact that this is not confined to the apex in every patient. In 80% of the cases, this is in the apex, but in few patients, it can be in the base that is affecting here. It can be in the mid-ventricular area, and in 1/3 of the patient, it can affect both ventricles as well. So if you use your imagination, the left ventricle looks like a Takotsubo, or the pot that is used to catch octopus. That's why it's called Takotsubo. About 1 to 2% of the patients that we see with acute coronary syndrome with raised troponin actually turns out to have Takotsubo. That is the medical literature, and unfortunately, we see a lot of patients in the emergency department and urgent care settings who come with chest pain, and we do the troponin. Troponin is elevated. We send the patient to cardiology. They do further workup. Some of them need angiogram, some of them need echocardiogram, many of them need both of them. And this is the database that shows that 1 to 2% of these patients actually have got Takotsubo cardiomyopathy. But again, this can vary from region to region. This can vary from the country to country. There may be some demographic variation. So this is overall picture that 1 to 2% of the patients with raised troponin suspected acute coronary syndrome actually has got Takotsubo. Now, as I mentioned earlier, that in 1990s in Japan, they found that Takotsubo was a new phenomenon. So further research happened worldwide, and it is found that this is not confined in Japan only. Worldwide, this condition is found. In 2011, there was an earthquake in Christchurch in New Zealand, where I am based at this moment. There was a large number of cases of Takotsubo following that earthquake. So obviously, it was a very stressful condition. It was a physical stress, emotional stress, financial stress, and that all lead to Takotsubo. So when I talk about that, these are the various risk factors that we need to think about when we think about Takotsubo. Most of the time, this is some stress. Again, this is negative stress most of the time, but it can be positive stress as well. And the male affected less than the female. So male-female ratio is 20 to 80. So most of the time, the Takotsubo patient that I have seen a few, all of them are female patients. This is the disease of elderly. I don't know why. There may be some reason for it, but young patients with Takotsubo was reported in medical literature. So although the risk factor is statistically proven to be correct, but in clinically effective or clinically meaningful terms, don't exclude Takotsubo just because the patient is young. There may be some genetic predisposition. Again, it was initially reported in Asians, in Japanese people, but now we find that actually a lot of non-Asian people also have got Takotsubo. Now, what is the pathogenesis? no one knows what happens, but there are some hypotheses, and there are some conflicting evidence as well. So initially, what happens is that the systolic function of the heart that can be similar or worse than in comparison to acute myocardial infarction. The initial diastolic function may be similar or better with stress cardiomyopathy. The hypothesis is that, as I just explained, that if there is excessive catecholamine, that can cause Takotsubo. There is a condition called pheochromocytoma, as you can realize that there is excessive amount of catecholamine from this tumor of adrenal medulla, and it is found that in a patient with the pheochromocytoma, they have got exactly similar echocardiographic picture like Takotsubo. So that supports this hypothesis that excessive catecholamine can cause Takotsubo. Any type of physical stress, emotional stress, financial stress, negative stress most of the time, but positive stress as well increases catecholamines. The patients who are intoxicated with catecholaminanergic drugs like cocaine or amphetamine, they can have similar presentation as well. We need to keep that in mind. Obviously, microvascular dysfunction plays some role. There may be association with catecholamine excess with microvascular dysfunction as well. Coronary vasospasm can cause it, but one of the feature with the Takotsubo is that no specific coronary artery is affected. So multiple coronary artery can be affected. So we need to keep that in mind. Dynamic left ventricular outflow tract obstruction can be responsible for this as well. So again, these are all the hypotheses, and nobody knows exactly 100% that this is the cause of Takotsubo or this is the underlying pathogenesis for Takotsubo. Now let's talk about how the patient present. So we'll talk about the history, the examination, and some investigations. So the main history is that patient has got some stress. So this is the history. We take it not very seriously most of the time. That is, I will have to be very honest that that is what I do as well. So, but we need to give some emphasis on the physical or emotional stress, some social factors that we need to consider. For example, if there is a death of the near or dear one, like in my patient, the husband died, the cat died, the dog died, the chicken died. These are all the emotional stress that led to the Takotsubo. If there is some domestic abuse, we need to consider that. And domestic abuse itself has got some risk factors that we need to think about that when we take the history. Even if the patient comes with chest pain, young patient coming with chest pain, consider this domestic abuse that may cause the Takotsubo. If there is too much argument with the colleague, with the family members, with friends, family, over the recent years, the various social media platforms, Facebook, especially Instagram, which I never use, that can be a source of the arguments, stress, and that can cause Takotsubo as well. If there is some catastrophic medical diagnosis like a terminal cancer, that can lead to Takotsubo. Financial loss like defaulting of the mortgage or losing the job. Especially in COVID situation, there are a lot of people who have lost their job in Europe. I know many of my known people, friends, family members of the friends, they have got this financial stress. If they come with chest pain, Takotsubo will be in my radar. Natural disaster, as I've just mentioned, that in Christchurch there was an earthquake in 2011, and many patients ended up with Takotsubo. Acute medical illness like some intracranial hemorrhage. I saw a patient 4 years ago in intensive care unit. I can still remember. The patient has got intracranial hemorrhage, and a formal echocardiogram was done, and which showed Takotsubo cardiomyopathy. So let's talk about how the patient present. So most of the time, in about 3/4 of the time, the patient presents with chest pain, and this chest pain is similar or comparable to that of the acute myocardial infarction or ischemia or acute coronary syndrome. So it's a dull aching pain radiating to the arm, right arm, left arm, neck, jaw that can present. Some of the patients, about half of the patients, present with shortness of breath, especially in elderly patients, diabetic patients. They can present with this type of presentation. If the patient has syncope, almost 1 in 12 patients can have Takotsubo type of presentation with the background of syncope. Not many patients, but few patients with cardiogenic shock can have Takotsubo as well. And cardiac arrest, VT, VF, heart failure. These are some of the presentations of the Takotsubo. Now, some investigations. The most important investigations in the emergency department or urgent care setting, a 12-lead ECG. But also some of us can do a bedside echocardiogram. Of course, we can do the troponin. So these are the main investigations. Let's talk about the ECG features in Takotsubo. And less than 50% of the patients can have ST elevation. So we know that there are 20 different conditions that can have ST elevation, including STEMI. So one of the differential diagnoses of ST elevation is the Takotsubo cardiomyopathy. ST depression can happen as well in about 11 to 12% of the 11 or 12, 1 out of 12 patients can have the this presentation in Takotsubo. TO inversion, as you can realize in my patient, there was extensive TO inversion in many leads, and that is a feature of Takotsubo as well. Prolonged QTC, that is one of the features, and in my patient has got actually prolonged QT interval. Abnormal Q wave, some people might think that this is an old MI, but don't forget that this can be Takotsubo as well. Sinus tachycardia can be a presentation in the ECG. Cardiac enzymes, obviously, when a patient comes with troponin, at the top of our list is could it be myocardial ischemia or acute coronary syndrome? So invariably, we send troponin. The median elevation is about 8 times upper normal limit in case of Takotsubo. And we have explained the mechanism that if there is excessive catecholamine, that can cause vasoconstriction, that can cause myocardial ischemia or infarction, and that can cause the raised troponin. Some patients can have raised creatine kinase as well, but it can be normal. BNP can be elevated in 83% of the patients. So let's talk about the specific diagnostic criteria. We call this Mayo Clinic criteria for Takotsubo. The most important diagnostic criteria is echocardiographic feature, which is transient left ventricular systolic dysfunction. So what happens is, I'll show you my echocardiogram in a minute. So patient can have the hypokinesia, they can have akinesia or complete standstill, or they can have abnormal movement. It can be usually apical, or it can be basal, they can be mid-ventricular. If the patient is taking the angiogram, the cardio-cath lab, an angiogram is done, they can have, usually it is normal angiogram. So there is no acute plaque rupture, there is no blockage, usually that is quite uneventful. If we do the ECG, there are some abnormalities as we have just explained, but according to the Mayo criteria, the ECG will be, there will be some new abnormality. Even if the ECG is normal, they can have raised troponin. And we need to exclude pheochromocytoma and myocarditis. Sometimes it can be quite difficult in the emergency department or urgent care to exclude pheochromocytoma and myocarditis. So diagnosis of Takotsubo can be a little tricky. We cannot quite 100% confirm. That's why if you suspect Takotsubo, consult a cardiologist and get some further input from them. Now let's talk about the echocardiography. As we have just mentioned, patient can have some hypokinesia, akinesia, bradykinesia. In about 80% of the cases, this is apical. In 14% of the cases, this can be mid-ventricular. In 2% of cases, it is basal. Focal can be 1.5%, and global is rare. In 1/3 of the patients, this can be biventricular, and ejection fraction is reduced. So let me show you this echocardiogram that I have done in my patient in a small ED with very limited resources. So this is a apical four-chamber view. If you're already familiar with it, you can skip the video. But if you are not, then let me show you the various parts of this heart at first. So this is the left atrium, sorry, this is the right atrium here. This is the tricuspid valve here. This is the right ventricle here. This is the left atrium here. This is the mitral valve, and this is the left ventricle here. This is the infundibulum. This is the aortic valve. Now, if you carefully look at it, you can see a few things. Number one, the apex of the left ventricle, that is quite dilated, just like a balloon. Normally, the apex should be quite narrow, just like the right ventricle, which is here. And in this patient, the left ventricular apex that is quite dilated. And also, if you carefully look at it, that there is not much contraction happening in the apex. So this is called bradykinesia or hypokinesia. Normally, the wall of the ventricle should contract very well, as you can, and as can be demonstrated here in the base of the left ventricle, or the whole of the right ventricle, that the ventricular muscles, they are contracting very well. However, in the apex of the left ventricle, there is a very significant amount of bradykinesia or hypokinesia. So a few things we can find in this apical four-chamber view. Number one, the right ventricle is performing quite normally. However, the left ventricle has got apical ballooning. There is dilatation of the left ventricle, and it is looking like the shape of Takotsubo, or the pot that is used to catch octopus. We can also see some bradykinesia or hypokinesia in the apex of the left ventricle. This all leads to the diagnosis of, this is one of the diagnostic criterion for the Takotsubo or stress cardiomyopathy. Of course, this is not a formal echocardiogram, so we need to arrange a formal echocardiogram to confirm that. But the bedside echocardiogram was quite significant, and I was very confident that it could be Takotsubo. But obviously, I have not done the angiogram. I have not done the other. I have not excluded pheochromocytoma or myocarditis. So, from an emergency physician's point of view, it can be a little tricky to call it Takotsubo. All I can say is that this echocardiographic feature is suggestive of Takotsubo. Let me show you another slide, or another clip. So this is the substernal view. So this is the right atrium. This is the right ventricle, which is contracting very well. No pericardial effusion. And this is the left atrium, and this is the left ventricle. It's not very well demonstrated, but still, if you can see here, the apex of the left ventricle, that is a little dilated, and it looks like just like a balloon. So if we usually in echocardiogram, you need at least 2 or 3 different views. It's maybe it's going to be the uh, long axis, parasternal long axis view, parasternal short axis view, apical 4-chamber view, apical 5-chamber view, substernal view, suprasternal view. So at least 2 views are needed to make any diagnosis from the echocardiography point of view. But I was pretty confident to call it a Takotsubo. So I sent that patient, I called the helicopter, and the patient was transferred to the nearest cardiology department. They did formal echocardiogram, they did angiogram. Angiogram was negative, and formal echocardiogram also showed exactly similar presentation that I have just shown, and these are all suggestive of Takotsubo. Now, a little bit in further details, in-depth diagnosis of ECG. Let's talk about it a little further. So this is what happens in a normal heart. As you can see that this is the right atrium, this is the left atrium here, this is a tricuspid valve, right ventricle here, left ventricle here, mitral valve is here. This is the aortic valve, this is the ascending aorta. These yellow components, these are the conduction system of the heart. This is the SA node, which is the pacemaker of the heart, and this is the AV node. So every time there is some electrical activity generated from the pacemaker, it is transmitted through the internodal pathways to the AV node, and there is a little delay here. And then this electrical conduction is conducted through the bundle of His, right bundle branch, left bundle branch, and then we can catch this electricity through the electrodes. We can amplify it and get a graphical presentation which looks like this. So there is a P wave, which is actually representing the depolarization of the atria. There is a PR interval, that is because of the avinodal delay here. This is the QRS complex, which happens because of the depolarization of the ventricles. And then there is the T wave, which represents the repolarization of the ventricles. So it's a very basic ECG presentation. Now let's show what I do when we interpret the ECG. So every time we look at the ECG, we first of all confirm this is the right patient, right time, right speed, which is 25 millimeter per second. We look at the rate. There are different ways of doing it. And after I'm happy with the rate, then I look at the rhythm. Is it a sinus rhythm? Is it there is a block there? And then I look at the axis. Is it a normal axis between -30 to +90, or is it right axis deviation, left axis deviation, or extreme axis deviation? Once I'm happy with that, then I look at the PR interval and PR segment. I'll come back to that in a minute. The gold mine in ECG is obviously the QRS complex and the ST segment. So we look at that very carefully and make sure that the patient does not have any STEMI or any time critical emergencies. Once we are happy with that, then next thing I would like to do all the time is the QT interval. And I'll show you in this ECG of this patient what happened to the QT interval. Then I look at the AVR and other fine prints in the ECG. There are various parameters that we can look for. Whenever we look at the ECG, always correlate the ECG findings to the patient feature. So when we look at the patient with chest pain with some social stressors like husband died, cat died, chicken died, dog died, um, it can lead to the top differential diagnosis will be Takotsubo. So this is what we call synthesis. And we need to make some plans, think about the complications of this patient. So let's come back to the ECG of that particular patient that we have talked about. If we look at the rate at first, so we have got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So 15 multiplied by 6, so the ventricular rate is about 90 beats per minute. Every P wave is followed by a QRS complex. So this is a sinus rhythm. Look at the axis. In lead 1 and AVF, this is a left axis deviation or left anterior fascicular block. Then look at the intervals, the PR interval that is within normal limit. The P wave looks a little bit bifid, so it can be because of the left atrial enlargement, but it is not massive. It's not massive, so I will not call it left atrial enlargement still at this moment. If we look at the QRS complex, they are pretty narrow complex. No right bundle branch block or left bundle branch block pattern can be demonstrated here. If we look at the QT interval, from the beginning of the QRS complex to the end of the T wave, that looks like a little bit longer than the RR interval. So I would suggest that there is some prolonged QTC in this patient. If we look at the T wave, which is very obvious here, there is T wave inversion in lead 1, lead 2, AVL. There is inversion, subtle inversion of the T wave in V2, V3, V4, V5, and V6. Especially in V4, V5, and V6, there is very well demonstrated T wave inversion. This can be one of the features of the Takotsubo cardiomyopathy or stress cardiomyopathy.
It is a fantastic ECG, Avijit.
Thank you. All right, so the management. When we see a patient with Takotsubo or any chest pain patient suggestive of acute coronary syndrome, our management strategies are supportive management. For example, resolution of the physical or emotional stress. So if the patient has got chest pain, give some painkillers. If the patient has got some physical or emotional stress, try to address that. Sometimes it can be beyond the expertise of the emergency department. We may have to take the help from the social worker, from the psychological services as well. The specific management from Takotsubo point of view, we might have to consider cardiogenic shock, as we have talked about. 10% of the patient can have cardiogenic shock and heart failure as well. With regards to the disposition, invariably every patient from an emergency physician point of view needs a cardiology consult, and patient needs admission for repeat ECGs, echocardiogram, and angiogram, and that is exactly what we have done in our patient. With regard to the supportive treatment, I will give some analgesia, which may be I personally prefer intravenous fentanyl if there is no allergy or other contraindications. It's difficult to titrate morphine, so preferably I give fentanyl. Emotional support, again, in this case, a social worker can be very helpful. Some anticoagulants I can give if there is no contraindication, especially if the patient doesn't have pericarditis, then I can give some anticoagulant. But if I suspect pericarditis, I will not give any anticoagulant. Usually I give some aspirin. After consultation with a cardiologist, we can give some ticagrelor or some or some clopidogrel as well. In real life, what I have done in my patient, I have given aspirin 300 milligram, clopidogrel I have given 300 milligram. Alternatively, we can give ticagrelor, Clexane, I have given 1 milligram per kg subcut, and I have consulted the cardiology for admission, ECG, echocardiography, and angiogram. Now let's talk about briefly about the specific complications or presentation of Takotsubo. In about 5 to 10% of patients, they can develop cardiogenic shock. There are two types. The first one is we'll talk about is the patient who does not have left ventricular outflow tract obstruction. In this case, we can give fluid, but be very careful that we don't want to overload the patient with fluid. So you can give some normal saline 250 ml boluses and maintain the blood pressure of MAP of 65 millimeter of mercury. We can give some IV dobutamine or dopamine. We need to be very careful that these are actually inotropic drugs, and sometimes they can actually make the thing worse. But if the left ventricular outflow tract obstruction is absent, then we can use the dobutamine or dopamine as a temporizing measure. If the patient still is hypotensive, we can use some vasopressor therapy, for example, phenylephrine or metadamenol. If there is a marked left ventricular dysfunction and all the above measures failed, the next thing is to do the intra-aortic balloon pump, which is an invasive process. Usually, by that time, the patient needs admission under cardiology or ICU, and the intra-aortic balloon pump can be inserted. Let's talk about another scenario where patient can have cardiogenic shock, but no left ventricular outflow tract obstruction. In this case, the most important thing is do not give any inotropic support, which we can give if the patient does not have left ventricular outflow tract obstruction. If we give inotropic support, then that can make the thing worse. Instead, we can give beta blocker, such as some labetalol or metoprolol. We can elevate the leg, which will increase the venous return, and that can help. We can give small fluid resuscitation, 250 ml of normal saline, because otherwise patient can develop pulmonary congestion. If that fails, next option is to give some metadamenol or some phenylephrine. And if everything fails, again, we can give intra-aortic balloon pump. So the take-home point here is be very careful about any inotropic support. Instead, you can give beta blocker, cautious fluid administration. We can give some vasopressor support. And if everything fails, get some help from the cardiologist for intra-aortic balloon pump. If the patient has heart failure from Takotsubo, the management is similar like the other cardiogenic, left ventricular failure or cardiogenic pulmonary edema. So first of all, we need to give oxygen, 15 liters with a non-rebreathing bag. Aim for a saturation of more than 92% if there is no contraindication like COPD. Next option will be to give NIV, CPAP, for example. We can give 10 centimeter of water pressure. We can give some vasodilator, for example, GTN infusion, 3 to 30 microgram per minute. Make sure that patient's blood pressure is stable. And the fourth option is to give some diuretics, such as intravenous furosemide. We can give 40 to 80 milligram IV. Now, let's put everything together. So, Takotsubo cardiomyopathy is a transient stress cardiomyopathy. It is not a permanent condition, but if we can remove the stress, then their condition usually improves. For diagnosis, we need to consider the history very carefully, especially the social history. We can take some help of investigations like a 12-lead ECG, which shows TO inversion, prolonged QTc, ST elevation, ST depression, Q wave as well. We can do troponin. It can be raised sometimes 8 times of upper normal limit, and echocardiogram if we are able to do it. Management is usually supportive from emergency medicine point of view. And if the patient develops complications like the heart failure or cardiogenic shock, then obviously they need hospitalization for specific care. Usually, the outcome of Takotsubo is good. If we can remove the stressors, usually they, with some supportive treatment, that they get better. In my patient, after 4 days of hospital admission, she was discharged home and she is doing very well. So the main big boxes in this presentation, we have set up some goalpost or signpost at first in the first slide. We try to find out what is Takotsubo. We talked about that briefly. We have also talked about how to diagnose it from the history, examination, and investigations. Specifically, we have talked about the ECG features, echocardiographic features, and also we have shown you some echocardiography and some ECG from my own patient perspective. We also talked about the management of the patient, which is very important. So if we can focus on these various aspects, then we have got some a good understanding about Takotsubo. Now, for further reading, there are lots of articles. The most important articles that I have found was by this paper from Abhiram Prasad, who is a cardiologist, I believe, in the UK. He has got this article in Up to Date that talks about both diagnosis and management. So if you want to know further, I would suggest get hold of those papers, and they are really good. There are quite a few papers about the demographic variations, and I have talked about the happy heart syndrome. So this is on the basis of the Takotsubo worldwide database, and it shows that about 5% of the patients actually do not have broken heart syndrome, but they have got happy heart syndrome. They are so happy that their heart got some vasoconstriction and ischemic event, which is I found very, very interesting. All right, so if you have got any further questions, please feel free to get in touch. You can contact me through email, through my website, or through Twitter. Thank you very much, and thank you, Becky, for your help as well.
Okay folks. Thank you for watching the video. Hope you have enjoyed the video. You are so awesome. If you find it useful, please like the video, subscribe to the channel and share it with others. Please write comments below the video. For every comment that you write, positive or negative, I will personally give a cookie to my cat Lucy. I promise I will do. If you have any burning questions, constructive suggestions or some awesome ideas, please get in touch. We would love to hear from you. Your comments and suggestions are very important to us. You can contact us through email, Twitter or Dr. Barai's webpage. Thanks once again. See you soon. Bye for now.
Thank you, Becky. That was a very nice concluding remark. Thank you, everyone. Bye.